Okay, I am going to be doing a dry, clean dressing change on this patient's incision. Okay, this is their arm. They have an incision going this way, and this is their old dressing. So I'm going to begin by verifying the physician's orders and gathering my equipment. So I have my sterile saline, my sterile gauze, and my abdominal pad and my tape. Okay, I'm going to identify the patient. Tell me your name and date of birth. Okay. Now I'm going to perform hand hygiene and put my gloves on. Okay, so this is the soil dressing. So I'm going to remove this and place it in the biohazard bag. Okay. And their incision is right here along their arm. Okay, so I'm throwing this old dressing away in the biohazard bag. Right now I'm going to assess their incision. Edges are well approximated. It is pink. There's a little bit of serous English drainage. No redness, no warmth. Okay, now I'm going to take these gloves off. I'm going to perform hand hygiene again and put on a pair of clean gloves. Okay. So I have my sterile gauze. I'm going to open it, and then I'm going to pour my sterile saline onto the sterile gauze. Okay, now I'm going to clean the wound, and we're going to go from clean to dirty. 1 wipe per gauze. Okay, so here is the wound right here. So we're gonna go 1, clean to dirty, 2, new gauze, 3, okay, 4. Okay, so we have cleaned it. Now we are going, and we used a different piece of gauze soaked in sterile saline. Now we're going to dry the wound with a dry piece of sterile gauze. This is our dry gauze. Clean to them. Down. Another piece. Down. Another piece. Down. Okay. Now we're going to take a clean dry gauze and apply it to the incision. Okay, so here's our clean dry gauze. Okay. Now we're going to cover the incision with an abdominal pad. So open it up in an abdominal pad. Here it is. Okay. Now we're going to tape the dressing to secure it. Okay. So here's our clean dressing taped. Now I'm going to remove my gloves and perform hand hygiene again. All right, now I'm going to document how the patient handled the procedure, which they said they were in a little bit of pain, but it wasn't too bad. And I'm going to document what I observed about the wound previously. Okay, this is going to be a dry, sterile dressing change on an incision. So here's my patient. Okay, I've verified the physician's orders and I've gathered my equipment. I have my sterile gauze, my sterile gloves, my sterile saline, and my abdominal dressing. Okay, so I'm going to perform hand hygiene and put on my clean gloves. So hand hygiene. Okay, so now I'm going to take off the soil dressing. And I'm going to discard in a biohazard bag. Okay, Now I'm going to assess the patient's incision. It's pink. There's a little bit of searing with stress in. There's no odor. The edges are well approximated. Now I'm going to take off my gloves and perform hand hygiene. Hand hygiene. Okay, now I have my sterile gauze. So I'm going to open my sterile gauze away from me. Okay. And then I'm going to take my sterile saline and pour it over the gauze. Okay, now I will put on my sterile gloves. Okay, now I have my sterile gauze. I'm going to clean the wound. I'm going to go from clean to dirty, 1 wipe per gauze. Okay, so out, into out, in, out. Okay, now I'm going to take my dry gauze and dry it in the same manner. This is my dry gauze. 1. Okay. So now I'm going to take my dry sterile gauze and cover the incision. And I'm going to apply a sterile abdominal pad and tape it to secure it. Okay, there we go. Now I'm going to remove my glove and perform hand hygiene. And then I will document the procedure, the type of dressing I use, the type of gauze. I'm going to document about the appearance of the wound and that the patient responded very well and had minimal pain. Okay, this is going to be ostomy care. I'm going to verify the order and gather my equipment. So I have my washcloth, measuring paper, and the new ostomy bag, my ostomy scissors, and I have my biohazard bag. Okay, so I'm going to identify the patient. You can tell me your name and date of birth. Okay, and I'm going to perform my hand hygiene and put my gloves on. Okay, I'm gonna empty and remove this pouch that's currently on. Okay, so I'm emptying it. Now I'm gonna remove it. Okay, and I'm going to throw this in my biohazard bag. Okay, now I'm gonna assess the skin and clean it with my washcloth. Cleaning it. All right, the stoma is pink. No signs of infection, skin is intact. Now I'm going to measure the stoma. Okay, I have my pen, measuring it. Looks like it's 3.0. Okay, so now I have my new pouch and I'm going to trim my scissors. Okay, so I have trimmed it. Now I'm going to remove the adhesive from the back of this after I trimmed it. Okay, and I'm going to place the pouch on the okay, I'm going to place the patch around the stoma, pressing firmly to secure it. I'm going to close the end of the pouch. Okay. Now I'm going to remove my gloves, perform hand hygiene, and I'm going to document how that I did the procedure, how the patient responded to the procedure, and the observations of the stoma. In order to assess a patient's risk to getting a pressure ulcer, we use the Braden scale. It consists of 6 subscales, and the total scores range from 6 to 23. The lower a Braden score indicates a higher level of risk for pressure ulcer development, and the subscales include like incontinence, immobility, nutrition, and a few other things. Okay. And whenever someone has a pressure ulcer, we do stage it. Stage 1 would be non-blanchable redness, and the skin will be intact, and it's usually over a bony prominence. Stage 2 is partial thickness. It is the partial thickness loss of the dermis, and it presents as a shallow open ulcer with a red-pink wound bed without the slough. It presents as a shiny or dry ulcer without bruising. Stage 3 is full thickness skin loss, so subcutaneous fat may be visible, but you will not be able to see bone, tendon, muscle. Stage 4 is full thickness tissue loss, so tissue loss, you will be able to see exposed bone, tendon, muscle, subcutaneous fat. Okay. Next we have unstageable. The depth is unknown. The wound is covered with usually like black eschar or slough, so you have no idea how deep it goes because you're not able to assess it. And then a suspected deep tissue injury, the depth is also unknown. It'll be purple or maroon, localized in an area. The skin will be intact, and it's like a blood blister, and it could be caused by soft tissue damage from pressure or shear. Now, types of dressings and bandages. So we have gauze. Gauze absorbs excess fluid from injuries that produce from damage. You want to use this on an infected wound, wounds that require wrapping or extra packing, injuries that require frequent dressing changes, or injuries with excess discharge. Right. Then we have foam. Foam keeps the area moist, and moisture accelerates wound healing, and it protects the wound from harmful bacteria. So you want to use this for pressure ulcers, minor burns, skin grafts, or diabetic ulcers. Then we have the transparent film, so that could be the Tegaderm. You use over IV. And the reason we use the transparent film is so you can assess the site, or whether that be the doctor or the nurse. So you want to use it for IV sites that need to be assessed, lacerations that need to be assessed, and abrasions that need to be assessed. Then we have hydrocolloid. It's the gel made by hydrocolloid, keeps the wound moist, and it promotes faster healing. So we use this for burn wounds, necrotic wounds, I want to say stage 2 pressure ulcers and venous ulcers. And then hydrogel, it acts as a wound dressing that intentionally adds moisture to the injury. The healing rate is increased with the additional moisture. So you want to use this for very dry wounds, wounds with dead tissue, or painful or necrotic wounds. Whenever you're documenting, assessing a wound and documenting, you want to assess the location of the wound, the type of wound, whether it be a laceration, abrasion, puncture, the measurement of the wound. If it's a pressure ulcer, you want to measure the depth along with the circumference, the tissue color, the drainage, the amount, and the type of drainage, would be purulent, serous, sanguis, the odor of the wound, if there is any. You want to assess the surrounding skin and the wound edges. If you have an incision, you want to assess if the incision is well approximated, which means if the skin is still together. You want to document the type of dressing you used and how often you've been changing the dressing. And then you also want to document the patient's pain level before, during, and after the dressing change. at types of drains. So we have a Penrose drain that's usually used in wounds after surgery where there's dead space present or when an accumulation of fluid is anticipated. They work by capillary action, gravity overflow, or fluctuations of pressure gradients caused by body movements. Then we have Jackson-Pratt drains. These apply continuous suction through the collection reservoir, and then when the reservoir is collapsed and attached to drain tubing, it creates a negative pressure that pulls fluid through the tubing.